Innervation of the heart. As you know that the heart is an internal organ, and therefore its nerve supply coming from the autonomic nervous system. The parasympathetic would be represented by the vagus nerve, and of course the sympathetic coming from the sympathetic trunk. And all these nerves, they would form plexuses. In the heart's case, it would be the cardiac plexus. So let's talk about these plexuses and how they are formed, and in details let's go and see how the heart is innervated. The heart is supplied by, of course, the autonomic nerve fibers from the cardiac plexus, as we mentioned, which is often quite artificially divided into, of course, superficial and deep. The cardiac plexus lies on the anterior surface of the bifurcation of the trachea. This is a good landmark. And by the way, many events we've mentioned, they are taking place at this plane. The bifurcation of the trachea is occurring at the intervertebral disc between T4 and T5, the plane that connects this intervertebral disc to the angle of Lewis anteriorly. Above it, the superior mediastinum. Below it is the inferior mediastinum. The arch of the aorta begins and ends at this level. The ascending aorta ends at this level. The descending aorta begins at this level. The tracheal bifurcation occurs at this level as well. Of course, today we are talking about the the cardiac plexus is located at this level as well. Many events are taking place at this level, the level between the superior and inferior mediastinum. But this is not our today's subject. So there is a cardiac plexus in front of the bifurcation of the trachea. This plexus is formed, as I just said, from sympathetic and parasympathetic fibers, as well as visceral efferent fibers, which can bring, of course, the nociceptive fibers from the heart. So mainly sympathetic and parasympathetic. Let's go to this slide here. This is a cross-section in the spinal cord. In all spinal cord segments, you would see of course, the anterior and posterior horns. This is the ventral horn. This is the posterior or dorsal horn. This is sensory. This is motor. And of course, from segment T1 until L2 in most textbooks, some say L3, you would find also another horn, the intermediolateral horn, or simply the lateral horn, which is sympathetic. So therefore we used to say the sympathetic nerves are the sympathetic cells in our body are located only in these columns and only in certain segments of the spinal cord, T1 until L2, and therefore we used to say thoracolumbar, thoraco from the thoracic segments, and the upper two lower upper lumbar segments, thoracolumbar outflow. So if you need sympathetic, these are the places where you can get them from. Now, so the presynaptic sympathetic fibers coming from the lateral horns of the T1, T2, 3, 4, 5, and then they should go as all sympathetic nerves through the sympathetic chain. Here, of course, some of them they would pass and synapse here in the sympathetic chain. Generally speaking, the presynaptic, they are different in the way they reach the sympathetic trunk. Some of them will just go up to reach the neck, and from there to reach the of course with the arteries to reach the head. So I will not talk about this anymore. Presynaptic from the lateral horns from T1 until T5. These nerves, they just synapse in the sympathetic trunk, and their post-synaptic fibers traverse the cardiopulmonary splanchnic nerves and the cardiac plexus to end in the SA node and AV nodes. So in this here, thoracic, sympathetic, cardiac branches, as you can see, they are coming after synapsing in the thoracic in the sympathetic trunk. So the presynaptic are coming from the lateral horns, then they join the sympathetic trunk. After that, they are becoming postsynaptic, and they of course contribute to the cardiac plexus. Now they reach mainly the SA node, the AV node, and of course, as you can see here, they reach the muscles themselves, but they affect the conducting system mainly, because you have to all the time remember that the heart has its own conducting system. It does not need nerves to initiate contraction, and this is very important. The sympathetic and parasympathetic coming to the heart are just to either accelerate the rate or to decrease this rate. So this is very important, and you need to appreciate this fact. Nerves for the heart are just to regulate its work, and of course some of them to transmit the pain and etc. But they are not motor to supply and initiate, of course, contraction. This is not the case. So if we go back here, sympathetic stimulation, adrenergic stimulation of the SA node and conducting tissue increases the rate of the depolarization of pacemaker cells, while increasing the atrioventricular conduction causes increased heart rate, impulse conduction, and force contraction. So everything here is stimulated by the sympathetic nervous system, is becoming more and more in its intensity, of course. So that was the sympathetic innervation. However, there is also a very important fact I want to talk about here. Sympathetic arteries, they have sympathetic innervation. So the coronary arteries, what about them? They also supplied by sympathetic nerves, and you would assume that sympathetic nerves reaching out the arteries, as I discussed that with you in the histological I think lecture, in the histology lecture. We talked that arteries, they have sympathetic nerves in their adventitia. Adventitia, they secrete the sympathetic triad, which is ATP, norepinephrine, ATP, and neuropeptide Y, mainly norepinephrine. And this norepinephrine would cause certainly constriction of the blood vessel. Now, if you saying that the sympathetic innervation is to increase the rate of the heart. This means more oxygen should go to the heart, and this means that the coronary artery, they should be relaxed to get more blood. So that's why we need to ask what is the influence of the sympathetic nervous system on the coronary arteries, and the answer, of course, in this slide. As the sympathetic nervous system approaching the heart and increasing everything that we mentioned, it does totally the opposite on the coronary arteries. It increases blood flow through the coronary vessel to support, of course, the increased activity. Most adrenergic receptors on the coronary blood vessels are beta 2 receptors, which when activated by norepinephrine, cause relaxation or perhaps inhibition of vascular smooth muscle, and therefore dilatation of arteries. This supplies more oxygen and nutrients to the myocardium during periods of increased activity. So the sympathetic nervous system accelerates the work of the heart. At the same time, it would inhibit the smooth muscle within the walls of the coronary arteries, which may cause, of course, relaxation and to drag more blood supply to the myocardium. What a genius design of the heart and its nervous system, the sympathetic, of course. Now, as we mentioned, the cardiac plexus has in it sympathetic and parasympathetic. The parasympathetic here, you don't need to think about it twice. It is the vagus nerve. Let's go back here and see. This is the vagus nerve, and the vagus nerve would certainly give branches. This is the contribution from the vagus nerve to the cardiac plexus. So there is a real contribution from the vagus nerve towards these plexuses, though we can't follow it during our practical session due to many reasons concerned with the methods that we preserve our specimens. But of course, you need to appreciate it as it is here in most of the pictures. Sometimes we can demonstrate the large branches, but usually, unfortunately, we can't demonstrate this in our practical sessions. So the vagus contributes to the cardiac plexus. Postsynaptic parasympathetic cells bodies, of course, are located within organs as the parasympathetic system does all the time. The postsynaptic parasympathetic cells usually inside within the organ itself. The heart is not an exception. The atrial wall, these postsynaptic parasympathetic are located in the atrial wall, interatrial septum near the SA node and AV node. We will talk about them along, of course, the coronary arteries. Now, some of you would raise the question about the parasympathetic and the coronary arteries. Most arteries, they have only sympathetic with local mechanism that dilates the arteries, and we already discussed that, and they don't need the parasympathetic to relax them. They would rather be under the control of endothelium, sympathetic nerves, and this orchestrated work is enough to relax and maybe constrict the blood vessel. Now, the only exceptions that you can find parasympathetic arteries within glands, and yet there also we are not sure that this parasympathetic going to the gland itself or to the arteries, but they are there and in the coronary arteries. Now, of course, the heart itself has a tremendous load of work to perform every minute, not every hour, every minute. So that's why I don't think local mechanisms here in the coronary arteries would be effective to relax maybe the coronary arteries, and that's why the parasympathetic also can be here, but they would also play the constriction part and modulation rather than anything else. So the parasympathetic would reach not only the heart but the blood vessels also. Don't you forget that the coronary arteries here, they have beta 2 adrenal receptors that would certainly relax eventually the coronary arteries, and the parasympathetic here would I would assume to play neuromodulatory role in the activity of the smooth muscles or vascular smooth muscles in the artery. Anyway, let's go back to parasympathetic supply. Parasympathetic supply, it's approaching the atria, the interatrial septum, and of course coronary arteries. The parasympathetic eventually slows the heart rate, reduces the force contraction, constricts the coronary arteries. Postsynaptic parasympathetic fibers release acetylcholine, which binds with muscarinic receptors to slow the rate of depolarization of the pacemaker cells and atrioventricular conduction and decrease atrial contractility. So it is the opposite to that of the sympathetic nervous system. Anyway, as you can see, the sympathetic and parasympathetic systems, they contribute to the formation of the cardiac plexus. It has a sympathetic innervation coming from T1 until T5. They synapse in the sympathetic trunk, and from the sympathetic trunk they contribute as postsynaptic nerves to the cardiac plexus. On the other hand, the parasympathetic coming from the vagus nerve also contributes to the formation of the cardiac plexus, and the heart here is getting from the cardiac plexus both sympathetic and parasympathetic. Both they orchestrate the work of the heart, either increasing or decreasing the heart rate, but never innervating the myocardium of the heart. They reach especially the sympathetic part, reach the myocardium, but there they are not there to initiate contraction. Which part initiates contraction? It is the conducting system, and we will talk about it just in minutes. Now, the cardiac pain, as a visceral organ, all the visceral sensory innervation would go back from the internal organ via the sympathetic nerves. Of course, the sympathetic nerve would take this back to the, of course, the targeted or final segments that we mentioned them, T1 until T5, and therefore you need to also appreciate this fact. The nature of pain varies. The cardiac pain is just the amount of variability in the cardiac pain is just amazing, from a severe crushing pain to nothing more than mild discomfort, and this is something you need to appreciate because really most of them would come and with a crushing pain in their chest, severe pain, but some of them would just come to your clinic or emergency department with mild discomfort. And we need to talk about this part. Cardiac referred pain is a phenomenon whereby pain stimuli originating in the heart are perceived by a person as pain arising from the superficial part of the body and from the left upper limb, of course. So pain originating in the heart stimulates the sensory nerve endings in the myocardium. The afferent nerve fibers ascend to the central nervous system through the cardiac branches, as I told you, of the sympathetic trunk, and enter the spinal cord through the posterior root of the upper four thoracic nerves. Sometimes they say from T1, T5, T1, T4. It doesn't matter. Variability is always there. Now, remember that the heart is in the middle mediastinum, and the whole middle mediastinum is located in the inferior mediastinum, and the inferior mediastinum is located below the level of this plane between the sternal angle and the intervertebral disc between T4 and T5. So the heart is lying below these segments that we mentioned, and therefore the pain is not felt in the heart but is referred to the skin areas supplied by the upper four thoracic nerves, and the upper four thoracic nerves, we call them intercostal nerves, as they supply the first and second, third and fourth intercostal spaces, motor and sensory. So the patient would come complaining about pain in the upper part of the chest, and of course there are some connections, and we need to explain this on anatomical basis, not anything else. The skin areas supplied by the upper four intercostal nerves that we mentioned, and by the intercostobrachial nerve, which is a nerve from T2, are therefore affected. So this area, this nerve is supplying the skin on the, of course, the upper limb, and this nerve, the intercostobrachial nerve, communicates with the medial cutaneous nerve of the arm, which is branched from the medial cord, and it is distributed to the skin on the medial side of the upper part of the arm. So that's why there is a communication between T2, represented by intercostobrachial nerve, and the medial cutaneous nerve of the arm, and therefore your brain may, or the patient's brain may take this as a pain coming from the left side of the arm, not a pain coming from the heart itself. Why? Because obviously the afferent signals coming from the heart and from the intercostobrachial nerve are going to the same segments, and therefore the patient may think that the pain is coming from the medial side of the arm, and this is something we already discussed, referred pain. The problem is in one area, and the patient is coming to you complaining about pain that is in a different place. The problem in the heart, and the patient is complaining about pain in his left arm. What we need to do, any patient coming to you with pain in his left arm, of course you need to ask many questions, but you need to think, and you never ever forget about the cardiac problems, especially myocardial infarction. Now, the story with the pain and the cardiac problems is not to be finished there. it is more complicated. A certain amount of spread of nervous innervation must occur within the central nervous system. That is for sure. Uh, and this can't be explained on anatomical basis. We could have explained this. There is a connection between the intercostal brachial nerve and the medial cutaneous nerve, and this is something can be explained. However, what is the relation between the neck and the jaw? There is no any anatomical connection between the nerves that supply the neck and the jaw and those that supply the heart, and therefore our explanation that a certain amount of spread of nervous innervation must occur within the central nervous system. After all, the brain is the main analyzing area, if you would like, that understands signals coming from everywhere. So for pain is sometimes felt in the neck and the jaw. We can't explain this on anatomical basis, and therefore we may suggest an explanation that this must be happening at the level of the brain itself. Now, also you need to focus on this. Myocardial infarction involving the inferior wall or the diaphragmatic surface of the heart often gives rise to discomfort in the epigastrium, and this I have seen it in elderly patients. Some of them, they just come to your clinic complaining about discomfort, not pain, but just discomfort in their epigastrium where the stomach should be there, and this is a disaster to not think about the possible myocardial infarction to the diaphragmatic surface, and you should not miss these patients. The bottom line is epigastric discomfort should be in certain group of people, of course. You have to ask about and to investigate and to think about the diagnosis of myocardial infarction. And as we said from the beginning of this lecture, not all patients with myocardial infarction would come and complain about severe pain in their chest, but would rather have some of them complaining about pain in the left arm, referred pain, or in the left jaw and the neck. And some of them, they would just come and complain about epigastric pain, discomfort. And this also we can explain on anatomical basis. The diaphragmatic surface is just sitting on the, of course, central tendon of the diaphragm, and we know that the diaphragm has not only the phrenic nerve supplying it, but also the intercostal nerves, the lower ones, the 7th, 8th, and 9th thoracic spinal nerves. They give rise to referred pain in T7, T8, and T9 thoracic dermatomes and the epigastrium. So there is anatomical connection that the irritation from the myocardial infarction affecting the diaphragmatic surface may irritate the nerves that supply the diaphragm, and the diaphragm would certainly take this information from the T7, 8, 9 and send it back to the brain, and the brain may think this is coming from the epigastric area. So again, the final thing to think is this is just amazing how your brain can play with your pain coming from different areas. Uh, we barely could explain this pain here in the medial side, in the upper part of the body. We said about this, we could have explained this, but when a patient comes to you with pain in his back or in his right side, that would of course makes you think in different diagnosis, not thinking about the myocardial infarction, because you would certainly think that it should be on the left side, it should be associated with left arm or with the jaw and etc. But you have also to think about pain found in synaptic contacts, may also be made with connectors neurons, which conduct impulses to neuron on the right side. So pain originally coming from the left side, but it has to cross in certain areas, and the brain may think this is coming from the opposite side. So it could be from the back, it could be from anterior. People with diabetes, old people, usually they don't show the typical pain that we talked about. They usually come with epigastric discomfort, pain in their back. I've seen many of them, they coming to your emergency room and complaining about pain in their back between the two scapulae. And there have been many stories. You ask people what happened to this guy who died recently, who has died recently. They may say he just felt pain between the two scapulae and then he died. This is the cardiac pain. We need to think about cardiac pain as something that could be represented or unfolded as a typical pain in the upper part of the chest, which is in its way also not typical, radiating to the left arm, may also radiate to the left jaw, and dentists. They discover some people with myocardial infarction. They come to them complaining about severe pain in the left jaw, of course, and they should also think about myocardial infarction, and they should refer these patients to specialized hospitals. So the bottom line is this: you have to be careful with cardiac pain, epigastric pain, pain in the back, pain in the neck and the left side. All these should be, or you should think about myocardial infarction, and you should understand that cardiac pain could be found on in all these areas. Now let's talk about the conducting system. Here the conducting system consists of specialized cardiac muscle. They are cardiac muscle, specialized cardiac muscle. They are not sympathetic nerves. They are not parasympathetic nerves. They are certainly not somatic nerves. They are not nerves. They are specialized cardiac muscle, present in SA node, AV node, atrioventricular bundle, right and left terminal branches, the subendocardial plexus of Purkinje fibers. Now let's talk about each one of them. In this slide I need you to focus on the location of the SA node. It is of course located anterolaterally just deep to the epicardium at the junction of the superior vena cava and the right atrium, where you can see it here, near the superior end of the sulcus terminalis. So you can see it during practical session, but we surgeons, they know exact location of this node. More in this node, of course, physiology, I would leave it for them to deal with the rate and etc. But the important thing for me here, that the contraction signal from SA node spreads myogenically through the musculature. So until recently, we think that the signals are to spread through the atria to reach the AV node. Nowadays, we do think that there is intranodal pathways. I will talk about them by the end of this lecture, but certainly the SA node transmits or sends the signal towards the AV node. The AV node, this one is very important also, its location. This is what matters in anatomy. Is located posterior inferior region here, near to this coronary sinus. Of course, there is here the triangle, very complicated, with the between the coronary sinus and the eustachian valve and the tricuspid valve, triangle of Koch, or I didn't explain this triangle for you. I think it's for a bit advanced level for surgeons, cardiology, cardiac surgeons, and etc. So the location also can be found by the surgeons. They know this area. They know all the structures surrounding this area. The AV node then distributes the signal to the ventricles through AV bundle of Hess. Now, AV bundle, atrioventricular bundle, is very important as it is the only bridge between the atria and the ventricles, and it is within the fibrous skeleton of the heart along the membranous part. So I need you to focus on the pathway of the bundle of Hess, atrioventricular bundle. It is within the membranous part of the interventricular septum. Why is that? Why it's not running in the myocardium? For insulation purposes, and the best insulator here in the heart is nothing but the fibrous skeleton. So that's why the AV bundle is within the membranous part of the interventricular septum. Now, at the junction of the membranous part and the muscular part, so as I told you, the interventricular septum has anterior 2/3 muscular, posterior 1/3 membranous. Here we're saying that the bundle of Hess, as it descending towards the ventricle, lying in the membranous interventricular septum, as it reaches the muscular part of the interventricular septum, it divides into right and left bundles. Now these branches proceed on each side of the muscular interventricular septum, as you can see here, and then they ramify into subendocardial branches, Purkinje fibers. Now the Purkinje fibers extend into, of course, the corresponding ventricles. The subendocardial branches of the right bundle stimulate the muscle of the interventricular septum, the anterior papillary muscle of the through the septomarginal trabeculae. We talked about this moderator band, and the wall of the right ventricle. The left bundle divides near the origin, and of course it stimulates the IVS interventricular septum, the anterior and posterior papillary muscles, and the wall of the left ventricle. So the last thing about the membranous, about the this one, the bundle of Hess. When we talk about, I think this week would talk about the development of the interventricular septum, and I already talked about the membranous part of the septum, and I did mention that this is made out of 3 contributors, and sometimes some of them would not come and meet, and therefore we may have some newly born babies with defects in the interventricular septum, and we need to operate on these babies to, of course, to close this defect if it is large enough to cause symptoms. Now, unfortunately, the bundle of Hess, which is the only connection between the atria and the ventricle, is running right in this membranous part. So surgeons, as they preparing to repair this defect, they should bear in their minds the presence of the AV bundle of Hess, because if they just like get this area or they just make any cut in this area or damage, they would leave the heart conducting system of the atria separated from that of the ventricles. Of course, I would Purkinje fibers, they are easy to go. I think you can go through them. They are clear. Now let me summarize the conducting system for you. The SA node located in the right side of the heart near to the superior vena cava, and the AV node is located within the interatrial septa near to the tricuspid valve, rather the coronary sinus, in a triangle that all cardiac surgeons know very well. Then the bundle of Hess, which traverses the membranous part of the interventricular septum, and there it could be dangerous if we repair a defect in newly born babies, that when we operate on these patients, we need to take care of this bundle, and of course the subendocardial and Purkinje fibers. Of course, I would leave them to you to read them. Finally, scientists have noticed that impulses from the SA node have been shown to travel to the atrioventricular node, so from the SA node to the AV node more rapidly than they can travel by passing along the ordinary myocardium. And this scientists raised questions about the possibility that maybe there are a conducting system or pathways where the impulses travel from SA node to AV node. We used to believe that the signal from SA node to AV node is traveling through the myocardium of the atria. Nowadays, there have been more than one explanation saying that there are structure consisting of mixture of Purkinje fibers and ordinary cardiac muscle cells, and we believe that these pathways can immediately bring the impulses towards the AV node. They've been given the name of intranodal pathways. They are easy, anterior, posterior, and of course middle internodal pathway. They are connecting the SA node to the AV node, anterior, posterior, of course, and middle internodal tract. So the conducting system should be summarized, and you should think about it when we talk about arrhythmias. Any damage to the conducting system would lead to arrhythmias. Arrhythmias are associated, of course, with any problem with in the conducting system. Coronary arteries, they are associated with myocardial infarction. The myocardial infarction can affect the conducting system, can affect the papillary muscles, the contractility of the left and right ventricles. So they are all associated together. You need to know the blood supply. You need to know of course, the conducting system at all its, of course, details.